I think, NET tumors are very different to regular pancreas cancers. Secondary tumors in the liver are never treated surgically with regular pancreas cancer. But of course, because of the different biological personality of these NET tumors, it's often possible. And it's, I think if you have a pancreatic NET tumor with a limited number of liver secondaries, in general, I think the team would try and clear all of the disease. As to whether you treat the liver secondaries with microwave or surgery, there are sort of pros and cons for each approach. There's a lot to be said for taking the tumor out if you can, for several reasons. First of all, you get bits of the tumor to look at. We've talked a bit about Ki-67. And one of the things you learn when you take out the liver secondaries is that sometimes the Ki-67 looks a little different in different parts of the tumor. So there can be, if you take a needle biopsy, you get a tiny bit of the tumor. You may not necessarily hit the bit of the tumor that's the most active in terms of Ki-67. And the thing that determines how the tumor will behave is what bit of it is most active. So there's some benefit in having the whole liver tumor out for histology. Having said that, there are some situations where microwave would be entirely appropriate. Sometimes if a tumor is very awkwardly placed, or if it might need a huge liver resection to take out a very tiny tumor, it just may not be worth losing that amount of liver. So there are definitely situations where microwave would be appropriate, but in general, if you can resect the tumor surgically, I think there's a lot of advantages to that. I guess with the next question is how many tumors can you take out, and that's a very individual thing. I think if you can take out all of the tumors and leave enough liver left, then that's what you should try and do. So it's a very different treatment approach to regular pancreas cancer.
That's something that, it's an important point that I think it's just like sous-entendu. It's just below what you're asking. So if you had a liver resection first and then you've got one coming back, this is the question. There are two questions really in that. Should I have therapy after liver resection? That's called adjuvant therapy. Colorectal cancer, for example, patients after they've had surgery for the colon, sometimes for the liver, you'll have therapy for 6 months to try to prevent getting further disease. That's been looked at in a few studies, not very big ones, but it doesn't seem to work in neuroendocrine tumors, and we need to do further work on that. For example, PRT might be something to look at after patients have had big surgery to try to decrease that risk of metastasis or coming back into the liver, which are not infrequent, okay? That's the honest answer. But the real question, I think, is that if you have had a treatment to one liver lesion and now there's something else maybe turning up, we need to be careful that you might need to have maybe some chemotherapy rather than some local therapy or further surgery, because the biology might be a little bit more active, and we might need to give you something to turn off that activity, okay? So you might need something before going in maybe and doing further microwave therapy or surgery, and that's really got to do with how fast in the biology. Now, I don't know your particular case in mind, but they're the sort of question we would be asking. So sometimes it's pertinent to do surgery or radiofrequency ablation or microwave or local therapy on a little lesion, and sometimes it's appropriate to knock off the engine in that tumor that drives it before going in and doing it. So one of these things, I think, would be sort of open to discuss.